Hello to everybody. It's 2021. It's Wednesday morning, so it's Enjoy Science time. So let me first to say happy 2021 and lucky year, and hoping our lives will go toward normality this year. To all of you who are the attendees, without you, we could never do Enjoy Science. Thank you for being here in hundreds for each talk. I want to thank especially to the people who give talks to Enjoy Science during 2020. We very much appreciate your time and your effort, because it was a difficult year for all of you and for all of us. So you show to all of us, MD Anderson families, the fact that you love what you are doing and you love all of us as a cohesive group. And of course, I want to thank again to my co-host, Alessandra Ferraioli, to Dr. Giulio Draetta, and to Liz Kent, to Alison Gart, Laura Adame, for all the support and for putting all these things together. And let's start the show today. It is a wonderful occasion for me to thank to Jean-Bernard Durand for being with us. He is a wonderful clinician scientist who is working on a topic very important for cancer. He is working on the cardiology. It's professor in cardiology department, and it's working on the cardiac changes and effects on cancer patients. He has a wonderful preparation. He worked in Baylor College of Medicine also as a postdoctoral fellow. He had a residency in Loyola University, and basically he is a typical clinician scientist with love for both sides. For clinical side, he develops a cardiomyopathy program in MD Anderson, so he was able to build from scratch an important program for our cancer patients, and also a scientist. He basically discovered, when he was in Baylor, an important gene, troponin, for the familial cardiomyopathy, so he has a solid background in research. And I have to tell you that I prize Jean-Bernard, because from the time I started MD Anderson, he was coming continuously to discuss about the non-coding RNA and how he can apply new things in his research for his patient. Curiosity, it's a wonderful characteristic and quality of scientists. And with this, thank you, Jean-Bernard, for being with us. We are looking very curious for your talk, and please take out the show, and good luck with the presentation. Thank you again.
So thank you, first of all, for inviting me. You're absolutely correct. I think one of the things that is the most valuable of working at MD Anderson is the colleagues and associate we have here. And I would like to preface that I'm only at the beginning of this project, so anyone who's listening who can serve as a consultant, who can serve as a collaborator, I am very much open to that and would love to get your input and find ways that we could work together and fund some projects together. So unfortunately, I do not have any financial conflict of interest to report. So over the last 20 years that I have been here, what I have seen happen as a cardiologist is I've seen that the practice of oncology has shifted to these targeted therapies. There are now over 50 new agents that have been approved over the last 5 years for the oncology world, and I have highlighted in green is that these therapeutics that we have available and having a cardiologist involved should in fact support the use of these drugs. It should not lead to interfering or interrupting our patients' care. The treatment that we have from the heart perspective is really about prevention and early detection, and prevention for progressing on to heart failure or to any cardiac injury. The unfortunate thing is that there really are limited randomized controlled trials on prevention and on treatment. There really is not a lot, and the experience that we have is actually practice-based evidence. It's from what we have created here from working in an oncology environment and working with our colleagues. So I always like to put this slide up because If you didn't see the upper right-hand corner, you would be very much interpret this working slide as signaling for cancer, anti-cancer pathways. But in fact, these are pathways that are involved in cardiac signaling, that when you inhibit these pathways, you create in animals and in humans a phenotype of heart failure. So if you look, as an oncologist, you're going to see a lot of very common targets, such as the growth factors, PDGF, TGF-beta, EGF, the receptors, the coupling proteins. We understand that when we inhibit this in the oncology world, that leads to inhibition of proliferation, inhibiting angiogenesis, and inhibiting metastasis. So the very same pathways that we are inhibiting in the oncology world to treat cancer, we can demonstrate and have demonstrated both in animals and human that when you inhibit these pathways, you can create a phenotype of a dilated cardiomyopathy. That's where I think we share a lot, and unfortunately, we have not communicated very well in the past about these pathways and how we can share these pathways and figure out not only treatment, survival, but perhaps even drug development. It may be related to how we share these pathways, how we can turn off these pathways so that we can ignore the cardiovascular effects and in fact enhance the cancer effects. That is kind of the mantra by which I live every single day that I practice. So the classes of anti-cancer therapeutic drugs that are known to cause left ventricular injury in any sort of are the anthracyclines, the tyrosine kinase inhibitors, the epidermal growth factor inhibitors, and of course the immunotherapy. We have data on all of these. I'm only going to focus on the anthracyclines, but to those individuals that are listening to this talk, I want you to know that we have tissue, human tissue, as well as databases for all these other categories, the TKIs, EGRFs, as well as immunotherapy. So it's a fertile environment for cross-fertilization and for research. So as it relates to the anthracyclines are still commonly used, especially in the pediatric population. Half of all pediatric diagnosis of cancer still utilize anthracycline. I can speak from being on the IRB. The biggest problem that we have is we have not allowed children until recently to be enrolled in a lot of trials other than anthracycline. So we don't have a lot of information about how immunotherapy, TKIs, affects the heart in young children and young adults. The presentation from the injury can be anywhere from several days after the initial infusion of anthracyclines all the way to 20 years after they are exposed. These are the common malignancies that are used, that uses anthracycline, the sarcoma, rhabdomyoma, lymphoma, leukemias in some settings, osteosarcoma, Wilm tumor, and of course, breast cancer. And we see all of these patients routinely. What I will tell you from this study from Greg Armstrong, published in Journal of Clinical Oncology, when you look at the mortality of these children, starting from 5 years all the way out to 30 years, the blue represents the recurrence and progression mortality. You see that starts to level off. However, the non-recurrence, non-external causes in yellow, this reflects number one is cardiovascular disease, number two is pulmonary. So we start to understand that these survivors, if they don't recur, the most likely thing they will be dealing with is some sort of cardiovascular event. And that's where we come in, is to try to lower or blunt this yellow curve. Even external causes, such as psychiatric problems, suicides, are still significantly higher in the cancer patient than in the non-cancer patient. So what do we know about doxorubicin or adriamycin? We know that it was initially discovered in Italy, and it's an antifungal, and it was found over in the early 60s that it is an excellent target for treating certain types of chemotherapy and certain types of cancers. We learned this is the classic von Hoff curve. What we learned many years ago, and we still preach, is that once you receive over 500 milligrams per meter square, the incidence of heart failure really goes up very, very quickly. What we see in our practice is somewhere between 200 and 300 milligrams is where we start to see the most number of patients who have some sort of injury to the left side of their heart. So even though the graph is showing out here, most protocols, lymphoma, breast, sarcoma, they tend to use between 200 and 300 milligrams per meter square, so a relatively small dose. So this is a 40-year-old data that dates back to 1979, 4,000 patients. If they had signs and symptoms of heart failure, they were found, there was belief that this was secondary to anthracycline. At that time, assessment of left ventricular ejection fraction or left ventricular function was not being done. The echocardiogram, which is an ultrasound of the heart, was not routinely done. So the more recent data from Judith Swain, who is in Washington, D.C., she defined it more for what we now know as an EF drop of greater than 10 points is considered a cardiotoxicity. And when you look at the incidence between 200 and 300, I tell most of my patients that the incidence of having some sort of heart injury is between 8 and 16%. This is really more reflective of what we see. And when you get above 500, it's really 50%. So there is a term that we use in the cardiovascular world called reverse remodeling. Reverse remodeling is a reversal. It can be either partial or complete reversal of abnormal processes that cause the heart structure and dysfunction. Doug Mann, who is now at WashU, he was at Baylor, he defined this term that he called remission, which we think about remission in cancer, but we don't think about remission in heart disease. And he described this in the Journal of the American College of Cardiology in 2012 to describe that there is normalization of function and the cellular changes that provoke recovery of the heart sufficient enough that it prevents future heart failure events. So he was the first to coin this idea of remission. I always liked this term because we understand it very well in the oncology world. So when there's injury to the heart, we now know that the standard of care is to receive both an ACE inhibitor and a beta blocker. They need to be on both those drugs in order to have some improvement in their heart function. This is a very old study that still stands to this day, that when you add a non-selective beta blocker on top of an ACE inhibitor, there's a linear relationship. The higher the dose that you receive of this beta blocker, the greater the improvement in heart function. So every single one of our patients, if they can tolerate it, they go on both of these therapies. And I'm going to show you what our own data is about the recovery. It is not as high as we think it is. So this is a paper that was published in New England Journal of Medicine, and it looks at the hypothesis of two separate hypotheses of what leads to injury to the heart from anthracycline-based therapy. On your left is the concept of the ROS, the reactive oxygen species. So anthracycline binds with quinone and leads to formation of hydrogen peroxide and oxidative stress. This oxidative stress leads to DNA injury, it leads to protein carbonylation, and it leads to lipid peroxidation and destruction of the cellular membrane of cardiac myocytes, and ultimately cellular death and dysfunction. This has been the prime objective and understanding of anthracycline-related injury until about 7 years ago. What changed was this idea of topo 2 beta isomerase and its effect on DNA coiling on the oncology world, but we also learned how it affects DNA strands and injury within the heart and heart cells. through mitochondrial biogenesis. So those are the two separate methods. I'm going to go a little bit more into the topo 2 since a lot of the work was done here at MD Anderson by Ed Ye. This was published in Nature Medicine, and he identified, he created an animal that is a knockout animal for topo 2 isomerase beta. He deleted the gene and he created a phenotype from anthracycline-induced cardiotoxicity. So what he defines in his paper were that there are two types of topo 2 isomerase, an alpha and a beta. The proliferating cells, cancer cells, predominantly express topo 2 alpha. However, the adult heart only expresses topo 2 beta. Now, when you receive an anthracycline, obviously you're competing with both targets, both the alpha and the beta form. So the hypothesis, the newest hypothesis, is the injury that occurs is mediated by this topo 2 beta that is expressed within the heart. So he created these knockout animals that were with or without the deletion for the topo 2. And what he found was when you give anthracyclines in these individuals who have the presence and the deletion form, they have preservation of their EF, and when they have the topo 2 beta in the heart, then this mediates the injury that leads to a decrease in ejection fraction. He sacrificed the animals. He looked at this under MRI, and under MRI, you see that there are significant changes to the mitochondria. The mitochondria are swollen. There is injury. There is lipid deposition. And if you see the deletion arm, there's relatively normal cardiac myosin structure and function. The mitochondria are normal as well. Now, this was, of course, in animals. We'd like to see this in humans, and hopefully that's one of the things we can do through some collaboration we do as a group. But noting that in the beta plus versus the deletion arm, there's a significant change, even at a pathological level, that you see that occurs with the mitochondria and with the integrity of the myocytes. So the only drug that is approved to prevent this injury is called desrizoxane. It is not typically used by our adult oncologists, very common. Our pediatric oncologists do. It has an indication, ironically, only for breast cancer. Anything other than that is considered, if you will, an off-label use. So if you think about how we practice, how do we prevent injury, we really don't have a way that we do that at a clinical realm. What this drug, desrizoxane, was found to do from historical data was that those patients who were exposed to this, Xenocard is the other name, had a 3% incidence of heart failure. However, if they did not receive this, and from historical data, the incidence was somewhere close to 22%. If they received 300 milligram per meter square, that's right at the dose that we typically use for breast cancer treatment. So Maximilian Buya, who's a cardiac pathologist at UT Herman, we have been working with him for over the last 20 years. He reads all the pathology that comes from this institution, specifically from cardiac biopsies. And he was able to quantitate and come up with a quantitative method, a morphological grading of chronic anthracycline cardiotoxicity. The grade is from 0 to 3. And this comes from an adaptation of the Bellingham score, originally from Stanford University. And he incorporates this, and we incorporate the amount of injury in our patients at the time that we do an endomyocardial biopsy. So I wanted to show you what we typically do. This is an echocardiogram from a patient who received an anthracycline-based therapy. This is what we call a 4-chamber view. This is the left ventricle, the right ventricle, the tricuspid valve, the mitral valve here, and the ejection fraction here is around 30 to 35%. And then on the right side, what we were looking at is after we treated with beta blockers and ACE inhibitors, and the heart function had fully recovered. On your right side here, it's squeezing completely normally. This was just done with beta blockers and ACE inhibitors. So I wanted to show you what I do with these patients. So this is a procedure that we do from the right internal jugular approach. What we do is we can isolate the right internal jugular vein, and you see me bringing down a biotome that goes into the right ventricle. And so on the right side, you will see me open up the biotome. So I can open up the biotome and I can take a sample and it comes out. And so we take somewhere between 4 to 6 samples. This is done under conscious sedation. It is done as an outpatient. It takes me 15 minutes to do. And nearly 600 patients, we have a complication rate of 0.008%. So the complication rate is actually quite low. So the approach is to approach from the right internal jugular. We obtain 4 to 6 samples. We send 1 sample for electron microscopy. If the patient consents, we take 1 sample that is flash frozen in liquid nitrogen for future RNA studies. The total mass of the samples that we have per patient is somewhere between 5 to 10 milligrams. And mind you, this is the largest database in the world, and the only database in the world that we have these samples for all the different types of chemotherapy that lead to cardiac injury. So we're quite excited about collaborating with some of our colleagues here about what we can do with these samples. So here is a data that is from 389 of our patients so far, and we have close to 600. The natural history of what we see, this is only for the anthracycline aspect. So you see they start off with a normal heart function and they drop down to somewhere around 38% at that time. We start them on standard of care, and this is what we call group 1. Group 1, within 3 months, their heart function goes back to normal, and they remain normal even out to 56 months. Group 2 is what contributes all of our time and all of our resources and all of the healthcare dollars. They continue to deteriorate, and their heart function gets worse. If they qualify, we can put what's called a chronic cardiac resynchronization therapy, or a defibrillator, a special kind of pacemaker, to support them to prolong their survival and or improve their symptoms. If they fail to respond to that, then they get a left ventricular assist device. This represents a very, 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 very small sample size. So small, only 10 in the last 10 years have been candidates for left ventricular assist device. And of course, the hardest and worst outcome is to go on and get a heart transplant. So group 1, they normalize. Group 2, they continue to progress. So when we looked at our own data from 389 patients, we published this data in Journal of the Clinical Cardiology. We found that 58% of our patients actually recover, but 42% of our patients, in fact, do not recover. So that's where all of our time and all of our resources are spent, and that's where we believe a lot of our scientific effort is now going to be on these individuals who fail to recover. So this is data that comes from Italy, from an investigator by the name of Danielle Cardinale. And her data looks a little bit different from the MD Anderson data, because the number of percent of patients who respond is somewhere between 2/3 of patients within 1 to 2 months. However, after 6 months and after, if you do not start them on medical therapy, 0% recover. They never, so you're only working off a window of 6 months opportunity in order to improve their heart function. If you do not reach that 6th window, then none of those patients will ever recover. Furthermore, she looked at the event rate for those who respond versus those who failed to respond and those who have a partial response. The responders have an excellent cardiac-free event. However, if they fail to respond or they only respond by 10 points, they continue to have events such as stroke, atrial fibrillation, recurrent heart failure admissions, and ultimately death. So this is our own data that looked at two groups, predominantly those that had no recovery and those that recovered. In light gray, you see the probability of survival at 1 year is somewhere around 60%. However, if they have no recovery, then you see the recovery, the survival probability is somewhere close to 40%. So they don't live a lot after the first year if we are unable to get them to recover their heart function. So what do we know about recovery in general? This is data that comes from Gerald Dorn, who's at WashU. And mind you, this was not on anthracycline therapy at all. So in other words, there is no data that exists in humans that has looked at microarray or gene expression in human tissue that has been exposed or been injured to adriamycin. This is where the opportunity is really within the group, and some of you I'd like to collaborate with. So what he did was he took 12 patients who had severe heart failure and looked at two normals. The two normals are here, and he looked at a microarray and a heat map showing gene differential expression between these 12 patients. He looked at the pulmonary artery pressure, and he looked at BNP, which is a biomarker for heart failure. Also looking at their negative and positive correlation. And in panel C, he combined the two. He looked at individual profile of BNP, brain natriuretic peptide. He looked at the levels of pulmonary artery pressures that were elevated. And then the interface of these two groups, the 42, he looked at those individuals, their profile, and then ultimately only found 2 of the normal. And here is what he found. And I know this is a busy slide, but I ask you to focus up at the very top, EPAC2. EPAC2, it is a transmembrane protein that is responsible for transmitting adrenergic stimulation through cardiac myocytes. So that involves both the cyclic AMP and the GMP. And what you see there are a number of different downstream off-target effects from EPAC2 that involve TNF-alpha, that involve insulin growth factor, that involve BCL6, that involve insulin growth factor receptors. So a lot of the same targets that we're looking at in the oncology world, there are some downstream effect from this adrenergic signal. So here is what he looked at. He looked at this signal in the form of RT-PCR, quantitative PCR, and looked at the expression of this adrenergic signaling in those who recovered and ultimately had their left ventricular assist device explanted. The signal, there was a significant decrease. However, those who failed to recover, the EPAC2 continued to maintain, and in some individuals, they actually became higher. So this is an interesting molecule that I think would be fruitful for us to look at in the future, in addition to a number of other pathways that are involved in either oxidative stress or that involve the topoisomerase 2 beta and how the expression leads to recovery of the heart function. So going back to this data that we have almost filled in all of the clinical data and now are ready to look at some expression studies. We have patients that we have identified from group 1, and we also have patients that we have identified from group 2. Those patients who have progressed, who we've managed to keep alive, despite the best medical therapy. The interesting thing about both groups is there is no difference in terms of dose or drugs that they receive for treatment of recovery. So both groups are on ACE inhibitors and beta blockers. The only thing that separates the two groups are those that recovered and those that failed to recover, which we do not understand. However, we do have a biopsy that was done at this time point, and we have longitudinal data, clinical data, that we can tease out to figure out what has happened to this group. So here is the initial study design. We have a total of 569 total cardiac biopsies that were performed, of which 164 are anthracycline-based cardiomyopathy. 81 are immunotherapy from checkpoint inhibitors, and we have all the clinical data for that. I have contacted Jim Allison, and this is something we are interested in looking at as well for the future. And we have 324 other anti-cancer therapies that we have stored in liquid nitrogen, and we can do expression studies as well. So I talked to George about what some next steps are, and George gave me some very good advice. We did some QA. We found that we have excellent RNA signals, and what we're looking at doing is doing some RNA-seq to identify a unique expression that can predict recovery of heart function versus those who have progression of their disease. So we selected in group 1, we obtained 10 samples, and we have obtained 10 samples from group 2, those that have failed to recover, and we're going to look at a very hard endpoint, mortality versus survival. So the conclusions are that the anthracycline-based therapy are common, they're still common for childhood and for some adult cancers. The medical therapy has helped to recover heart function in only 52%, 58%. Half of all patients, they failed to recover their cardiac function despite receiving the standard of medical therapy, and they carry a very high mortality. There have been no studies that have ever been reported on human samples and what happens to their expression profiles when they recover their heart function or when they fail. So really, this is an opportunity for me to meet a lot of you about how we can collaborate to take this data and really try to put a story to this about profiling, about how these hearts can recover, about how we can use biomarkers and cardiac imaging to help to predict who will recover and who will not. So I'd like to acknowledge George because he's been a great sounding board for me to try to get this project up and running. We have the tissue, we have the clinical data. Now really what we need to do is try to apply the science so we can really try to understand what happens to these hearts that some individuals can recover and some cannot. And so I will leave it open there for questions and any comments and any collaborative efforts.
So thank you very much, Jean-Bernard. It was a wonderful talk because it showed to all of us who are focusing on cancer research the fact that there are a lot of topics outside the cancer very important, and in fact it's a pity to lose these patients due to heart problems. So let's start with some questions. So one question is, how do you explain this lack of predictive biomarkers for the patients who will do well versus the one who will not do well before the start of the heart problem? Because it would be very helpful to have some markers of any type, proteins, RNAs, any DNAs, SNPs. I know that you worked a lot on DNA studies in order to predict what children and what adults are predisposed to this type of adverse reactions.
So you are correct. In terms of biomarkers, the biomarkers in the oncology world has been very, very good predictors of progression of disease, of mortality, of survival. That has not been the same in the cardiology world. BNP is a very poor marker of predicting recovery. What it does predict is it predicts hospitalization. It predicts progression of disease. It does not predict recovery. Neither does troponin. We do not have these same kind of biomarkers. So we have looked at polymorphisms. There's only been one polymorphism that has been reported. Ironically, the polymorphism is from a gene that regulates beta-adrenergic regulation, and that polymorphism is a very good predictor of recovery. It just hasn't translated into clinical practice. I do have close to 300 human samples of DNA that we can look at these polymorphisms from our group and our experience, and see if we can tease that out more, but that is available. If someone is interested in looking at this, we can do that, but we have not looked at that individually.
Thank you. So it's like you have a mind connection with some speakers, because look what is the next question. Increased density of tumor-associated nerves with adrenergic phenotype is associated with poor prognosis in several cancer types, like pancreas, breast, head and neck. Targeting beta receptor on tumor cells with beta blockers improves the overall survival of some of these patients. Could this also be related to improved cardiac function?
Oh, that's a very good question. So, Anil Sood has been kind of the leader that I have been following his work here. He did some very elegant studies published in Nature Medicine showing that the tumor burden, specifically in endometrial cancer in animals, that you can decrease the tumor burden as well as angiogenesis by the exposure of these animals to beta blockers. He even is doing a clinical study where he is giving beta blockers to women prior to doing endometrial cancer surgery and following them longitudinally. So it is a great starting point to look at expression specifically in adrenergic stimulation. And furthermore, I think it would be very good to look at that in the expression profile to see how the RNA signals for adrenergic stimulation, to see how it interacts and leads to recovery of heart function. So I think that's a very, very good point and something I'd be interested in looking at.
Great, thank you. Another question. I presume that these studies can also be done in animals. Would that give you some insight regarding where to start looking for differences in recovered versus non-recovered cases?
So yes, these can be done in animals. I have not found an investigator here that is interested in doing that. I have found individuals outside of the institution, but as everyone knows, is once you start sending tissue, valuable tissue, outside of the institution, then we lose a lot of the intellectual property. So I would like to find some individuals here who would be interested in partnering and doing some animal studies, specifically with anthracyclines. So if anyone is listening or knows anyone, I would be very, very interested in doing animal studies that are parallel to the human studies that we would be doing.
Thank you. So another question. So the people are very excited about your talk. So great talk. Are there any safe chemotherapies that are underutilized and may be suitable for prevention of metastases in common cancers such as breast? Specifically, how good may be 6-mercaptopurine, a ribonucleoside analog, which is very effective in controlling chronic inflammation and also used for keeping some childhood leukemias in remission?
Yeah, so that's work that needs to be done. You're absolutely right. The data looks very, very good in the oncology world. We need to be able to bridge that with the cardiovascular world. We haven't done that yet. In the leukemia world, we have found that some work that was done by Stephen Kornblau, that cholesterol-lowering drugs, such as statins, are very, very good at controlling remission in patients with different types of leukemias. There is an investigator, Dr. Banu Arun, who is doing a study where she was giving statins to prevent recurrence of breast cancer. And she's doing a biopsy on the tissue and looking at expression as well. So this is an example where there's some very elegant work that is being done individually, and maybe as a group we can try to combine this to put together a greater hypothesis of how this can protect the heart. Anti-inflammatory markers that have been done, such as vitamin E, such as some of the other anti-inflammatories, have not teased out in human studies yet. So there's a lot of work that we still need to do in the human arm.
Thank you very much. So with this, I want to thank you for for your wonderful talk, and also very interesting because it brought to all of us a new aspect of chemotherapy. And of course, all of you were listening. This basically it's an invitation for collaboration because this is the basis of true science. And with this, I want to all of you to give a good news, exactly because of the excellent talks, very interesting, that come one after the other, and because of the hundreds of you who are attending Enjoy Science, we decide to continue for the full spring these sessions, be weekly, same Wednesday, same 10 a.m. And for Wednesday, 20th of January, we have Dr. Hagop Kantarjian, who will present us another very interesting topic, the progress of leukemias, and very important, his visions about the future. So with this said, again, from all our Enjoy Science team, not only the three people that you see here, but all the people behind the scene, Ellison, Liz, Laura, and all the other people. Happy 2021, keep making discoveries, and let's move forward science and clinic, and thank you being all together MD Anderson family. See you all in 2 weeks, and good luck with everything. Thank you, and thank you, Jean-Bernard, again for your talk. Excellent talk.